Today, we are zeroing in on one of the most pivotal epidemiological events of the entire COVID-19 pandemic. We're talking about the summer 2021 SARS-CoV-2 outbreak in Provincetown, Massachusetts.
I remember the headlines so vividly. It felt like the pandemic's victory lap had just been instantly canceled. I mean, Provincetown, or P-Town as most people know it, is this vibrant, incredibly dense vacation spot on the tip of Cape Cod.
Right, known for these massive, packed summer gatherings.
And this cluster of cases in July 2021, it wasn't just another regional spike. It was officially labeled the Sentinel Event. This was the thing that just shattered the optimism about vaccine immunity and forced this radical shift in how the world viewed the Delta variant.
It really did. And that's our mission today, to unpack the profound paradox of that outbreak. On the one hand, you had a massive cluster of infections, over 1,000 people testing positive.
In a community that was supposed to be one of the most protected in the whole country.
Exactly. Barnstable County, which includes Provincetown, had a really high baseline vaccination rate. Something like 68% of the eligible population was covered. And yet the virus just exploded.
But that's only half the story, right?
That's the crucial counterpoint. Despite this aggressive, widespread infection, you had a near total suppression of severe illness and death. So we're going to explore the specific, unsettling epidemiological data, especially the viral load findings that changed national policy overnight.
And then we'll look at the other side, the success of the rapid community-led response that contained what, genuinely could have been a catastrophic health crisis.
Yeah.
Okay, let's unpack this. So for you listening, let's just set the scene. Imagine it's early July 2021. For a lot of the U.S., restrictions were lifting. There was this collective sigh of relief.
A feeling of freedom, really.
Totally. And Provincetown was celebrating this. There were events. A lot of them targeted the queer community, like Bear Week, which means huge public gatherings, dense indoor mixing, and this feeling that, hey, we're vaccinated, we're safe.
It was the epitome of the post-vaccine normal so many people had dreamed of.
But as the data proved, the virus, and specifically the Delta variant, it had other plans.
That feeling of safety was immediately challenged by the emergence of a variant that had a significantly higher transmission capability than anything we had seen before. Provincetown just became this unfortunate, high-fidelity natural experiment.
An experiment that proved just how different Delta really was. So let's start with the mechanism. How did this even happen? It sounds like it was just high-density summer behavior meeting the, hypertransmissibility of Delta.
That's exactly right. It was a perfect storm created by this intense social mixing of a traveling population, all combined with the B.1.617.2 variant.
And the investigators, they narrowed it down to a pretty specific window, didn't they?
They did. The primary exposure window was concentrated between July 3rd and July 17th, 2021. And this window, it lines up directly with several major public gatherings and a lot of high-density, often indoor nightlife.
The environment was just ripe for it.
Absolutely. Ripe for a rapid transmission event.
And then the tracing began, and the scale of this thing was it was way beyond what anyone expected for a town with that level of vaccination. So what were the raw numbers that came out of the CDC and state investigation?
So the investigation identified 1,098 primary cases.
And just to clarify, a primary case means someone who was actually in Provincetown during that window and then tested positive.
Exactly. Either traveled to or lived in P-Town during that specific 2-week period. And the sheer number was startling enough, but what immediately made it more complex was the dispersion.
Right.
An additional 30 secondary cases were identified outside the immediate P-Town area, and these were spread across 20 U.S. states and the District of Columbia.
Wow. So this wasn't just a local problem. It was a nationally dispersed event, catalyzed by tourism. People were getting infected and then immediately taking the virus back to their home communities, from Boston to L.A.
That is the challenge of a tourist hotspot. Of those nearly 1,100 primary cases, about 57% were Massachusetts residents.
Meaning nearly half were visitors.
43% were visitors. And they weren't just from nearby. They were predominantly from major travel hubs. 26% from New York, 18% from California, another 11% from the D.C. area.
So that map of dispersion means public health officials had to try and coordinate contact tracing across all these different state and county lines. It must have been a logistical nightmare.
It drastically complicated containment efforts, yeah.
We know now that Delta was the villain here, but at the time, confirming that was crucial. What did the genomic sequencing tell us?
It confirmed Delta's total dominance. The B1.617.2 variant accounted for 99% of the sequenced genomes in the dataset. This outbreak was, without a doubt, driven almost exclusively by Delta.
Okay, but I want to pause on that genomic analysis because there's a really interesting technical detail in there. The investigation said that Delta was introduced from at least 40 distinct sources.
Right, 40 different introductions.
But then it also says that 83% of all the cases came from one dominant source cluster. How does that work? I mean, how do epidemiologists reconcile 40 separate introductions with one massive cluster? It sounds like something failed at a community level to contain those first few cases.
That's an excellent question, and it really gets to the dynamics of super spreading events versus just background transmission. You're right, 40 people may have independently brought the virus to Provincetown.
So you'd have these little separate chains of transmission.
Exactly. But the dominant source cluster, the one driving 83% of the cases, that suggests that one or maybe two specific highly efficient super spreading events happened very early on.
Like a single party or a bar?
Precisely. Think of it less as a failure to contain 40 separate chains and more like one specific high-density environment, maybe a crowded indoor dance party that allowed one infected person to transmit the virus exponentially before anyone even knew there was a problem.
So one fuse was lit, and that one just drove the majority of the outbreak.
It did, and it effectively masked all those other smaller introduction chains.
That one cluster exploding driven by Delta is truly terrifying, especially given how many people were vaccinated.
Let's shift to who's getting infected, because the demographics here are really important context for the community response.
The profile was highly specific, and it really reflected the typical crowd for the P-Town summer scene. The overwhelming majority of cases, we're talking between 87 and 90% among the fully vaccinated, were men.
They were also predominantly younger adults. 66% fell into that 19 to 49 age bracket, which immediately told investigators they were dealing with a group known for high mobility and, intense social interaction.
And this leads us to the statistic that just genuinely shook the global public health community at the time: the rate of breakthrough infections. We have been operating under this assumption that vaccines created, if not sterilizing immunity, at least a massive wall against infection itself.
And Provincetown proved that assumption wrong. Of the initial 469 Massachusetts cases they analyzed, a staggering 74% were vaccine breakthrough infections.
74%. And to be clear, for everyone, that means they were fully vaccinated, final dose, at least 14 days before they were exposed.
That's right. And if you expand that to the entire cluster of over 1,000 cases, it's actually 81% were vaccine breakthrough cases. This just showed definitively that Delta could evade the immune system at the level of infection. High vaccination rates were not enough to stop the spread.
That 74% figure, it's not just a data point. It's a failure of the pre-Delta epidemiological model. Can we get into which vaccines were involved?
Yes. The distribution among the fully vaccinated breakthrough cases was detailed. Pfizer-BioNTech accounted for 46%.
Okay.
Moderna was 38%. And the single-dose Janssen, or Johnson & Johnson, was 16%.
And how long after vaccination was this happening? Was it only people whose immunity might have been waning?
That's a great question. The median time from the final vaccine dose to when symptoms started was 86 days, so about 3 months. But the range was huge. It stretched from just 6 days after the final dose all the way up to 178 days.
So it wasn't just about waning immunity. It was happening to people who were considered fully protected and recently vaccinated.
Exactly. It dispelled that idea entirely.
Now let's talk about the symptoms, because this was the second major shock. Before Delta, the narrative was, okay, if you get a breakthrough, you'll be asymptomatic or maybe have the mildest of sniffles. What did Provincetown actually show us?
Provincetown showed us that Delta, when it caused a breakthrough infection, behaved much more aggressively than we expected. A massive 96% of all cases in the cluster reported symptoms.
96%.
And that rate was practically identical between the fully vaccinated at 96% and the non-fully vaccinated at 95%.
Wow.
This finding was so critical because it directly challenged that prevailing narrative. The idea was that the vaccine's only job was to prevent death. But the expectation was also that it would significantly reduce symptomatic illness. This showed that if Delta got past your initial immune response, it could still replicate enough to make you feel genuinely sick.
So the key takeaway is getting vaccinated meant you wouldn't die, but you were still going to have 5 pretty miserable days of illness. That must have been a huge disappointment for people who thought their vaccine pass meant total immunity.
It was a massive psychological shift.
So what were the most common symptoms in this big, mostly vaccinated group?
The symptom profile was classic COVID-19, but the prevalence was high. Cough was reported by 70% of symptomatic cases, congestion by 55%, headache 48%, loss of smell or taste also 48%, and fever by 44%.
And was there any difference in how sick people felt, vaccinated versus not?
Not really. The median number of symptoms reported was also similar. Vaccinated people reported a median of 5 symptoms, and non-vaccinated reported a median of 4. This symptom similarity was really the first indication that Delta was managing to replicate very efficiently, even with strong antibody protection.
This high rate of symptomatic illness must have forced researchers to ask the next and most critical question. If they felt the same, were they also spreading the virus the same?
Exactly. And that's where the viral load data comes in, which fundamentally changed everything.
Yeah.
That is the pivotal moment. The core virological finding was this assessment of viral load equivalence, and it was a direct, immediate catalyst for the CDC's updated guidance on indoor masking. And to really grasp the gravity of this, we need to move beyond just counting cases and understand the measurement they used, the real-time RT-PCR cycle threshold, or CD value.
We hear the term CT value thrown around a lot. For our deep dive audience, let's explain it with a bit more precision. What does the CT value actually represent when we're talking about Delta transmissibility?
So the seat value is a quantification method they use in PCR testing. PCR is an amplification process. Each cycle essentially doubles the amount of viral genetic material in the sample.
Okay.
The seat value is the specific cycle number at which the machine's sensor detects the virus crossing a certain fluorescence threshold. So a lower seat value means the test crossed that threshold very quickly, say in 18 cycles, which means there was a massive amount of viral RNA in the sample to begin with.
And a higher seat value like 35 cycles means there was very little virus to start.
Exactly. You needed more cycles to amplify it enough to be detected.
And the general consensus pre-Delta was that vaccinated people with a breakthrough would have high CDET values, low viral loads, and therefore be much less likely to transmit the virus. This was the whole basis for the CDC relaxing masking guidelines for the vaccinated in the first place.
That was the foundation of the policy. The assumption was that the immune system would suppress viral replication in the upper respiratory tract enough to make a vaccinated person a dead-end host.
And Provincetown just demolished that assumption. What was the actual CDAT value comparison there?
The comparison was shocking because the difference was negligible. The median seat value in specimens from symptomatic, fully vaccinated patients was 22.77.
Okay, 22.77. And for the non-vaccinated?
In comparison, the median seat value from non-fully vaccinated patients was 21.54.
So basically the same.
Look at those numbers. Not only are both of those medians quite low, which indicates high viral loads in both groups, but the difference of just over one cycle is not statistically significant at all. This finding suggested something profound, that symptomatic, fully vaccinated people infected with Delta were carrying viral loads that were similar to those who were unvaccinated.
That is the policy bombshell. Essentially the same amount of virus.
Yeah.
Which suggested that a fully vaccinated person with a symptomatic Delta breakthrough was just as capable of spreading the virus as someone who was completely unprotected.
It fundamentally invalidated the central epidemiological model that the CDC had been relying on. The high viral load implied that the body's memory immune response was excellent at stopping the virus from getting into the lungs, so preventing severe disease. But it was too slow to stop that initial, highly efficient replication in the nose and throat. It couldn't prevent massive viral shedding.
So you might clear it a bit faster if you were vaccinated, but at the peak of infection, you were just as much of a spreader.
At the peak of infection, the sheer volume of virus present was enough to drive explosive spread in a place like Provincetown.
And the genomic evidence provided the smoking gun for transmission between vaccinated people, something we were told was extremely rare.
It did. The sequencing and the epidemiological data provided strong evidence for multiple instances of SARS-CoV-2 Delta transmission from and between fully vaccinated individuals.
Oh, no.
The detailed tracing managed to identify 25 confirmed transmission events, and the genomic analysis suggested 64 additional potential transmission links that weren't even caught by traditional contact tracing. It just illustrates the scale of spread within this immune population.
And we know this cluster led to secondary spread outside of P-Town, which confirmed that, yes, the vaccinated were indeed effective spreaders.
Absolutely. Those 30 secondary cases identified outside Provincetown illustrate the reality of that onward transmission. And they happen in all sorts of settings, not just in the home, but in workplaces, social gatherings, even at summer camps.
So the reproduction number, the R0 for Delta, was still dangerously high, even with widespread vaccination.
That's right. The travelers, though protected themselves from the worst outcomes, were vectors of transmission across state lines.
This finding must have shot up the policy chain to the highest levels immediately. What was the direct, measurable policy consequence of the Provincetown data?
The consequence was immediate and it was comprehensive. This data, the high rate of breakthroughs plus the viral load equivalents, directly contributed to the CDC's urgent decision on July 27, 2021.
And what was that decision?
They reinstated the recommendation that all persons, including those fully vaccinated, should wear masks in indoor public settings in areas of substantial or high COVID-19 transmission. The whole policy of unmasking for the vaccinated, which was based on pre-Delta assumptions, was made obsolete by the real-world data coming out of Cape Cod.
The science just mandated a return to population-level changes.
It did.
So Provincetown didn't just tell us about one town's outbreak. It told the entire world that the Delta variant had fundamentally changed the contract between a vaccinated person and public safety. Immunity against severe disease did not equal immunity against transmission.
That is the key synthesis. It was a clear, unambiguous signal to public health systems globally. Vaccines maintain their primary life-saving purpose, but they do not provide the sterilizing immunity you need to achieve herd immunity through vaccination alone against Delta.
So you still needed layered protections.
Exactly. Masking, ventilation, density reduction, they were all still required to control community transmission.
So that's the first half of the paradox. We have aggressive spread, high viral loads, symptomatic illness among the vaccinated. So what does this all mean for the other half? If the virus was spreading so aggressively, how was disaster averted? I mean, Provincetown is geographically constrained and just packed wall-to-wall in the summer.
And this is where the story shifts dramatically. It goes from an epidemiological warning to, really, a public health triumph that's rooted in vaccine efficacy and community cohesion. The overwhelming majority of the infections, while they were symptomatic and widespread, were mild enough to be managed outside of a hospital.
And that's the ultimate crucial takeaway that allowed the town to avoid catastrophe.
It is.
The triumph of the vaccine was that it delivered on its core, life-saving promise. Near total suppression of severe disease and death. Let's quantify that, because amidst all the fear of high case counts, that detail can get lost.
The numbers are incredibly powerful. In that initial cohort of 469 Massachusetts cases, only 5 hospitalizations were reported.
Just 5.
5. 4 among the fully vaccinated, 1 among the non-vaccinated. And critically, only 2 of those required intensive care, and neither of them died.
So what does that work out to as a rate?
It means the hospitalization rate among the vaccinated cases was a mere 1.2%. And that's 1.2% of people who are symptomatic with high viral loads.
And most critically, 0 deaths were reported in the entire cluster of over 1,000 confirmed cases.
0 deaths. That is the ultimate proof that the vaccines were fundamentally working as severe illness blockers, even against a nasty, efficient variant like Delta.
And if this had happened pre-vaccine?
Had that same number of cases occurred in a pre-vaccinated population, the expected fatality rate could have been anywhere from, say, 0.5% to 1.5%. That would have translated to 5 to 15 deaths, dozens of people in critical care, and it would have likely overwhelmed the limited resources on Cape Cod.
So the community had this massive outbreak, but its highly vaccinated status basically turned a potential mass casualty event into something like a large-scale, miserable flu season.
In a sense, yes.
But containing the spread still required swift local action to stop the case count from spiraling forever. How fast was the local response?
The local town leadership, led by the town manager, moved with remarkable speed and decisiveness. By mid-July, they peaked at over a 15% positivity rate on July 15th.
Which is an alarming number. It signals uncontrolled community spread.
A truly alarming threshold. But due to these rapid interventions, the average quickly dropped and stabilized below 5%. It settled at 4.7%.
So what were the key actions that made that drop possible?
It was a rapid, comprehensive response. This included the immediate reinstatement of an indoor mask mandate, issuing a direct public health advisory to all residents and visitors, and dramatically expanding access to mobile rapid testing services.
So they made it easy to get tested.
Very easy.
Yeah.
They mobilized testing sites aimed specifically at tourists who needed to know their status before they went home, and also for the international hospitality workforce that was so central to the town's summer economy.
I remember the town manager actually framed the whole outbreak as a positive story, which sounds so counterintuitive. Why that PR perspective?
It was a crucial framing. He argued that the story was positive precisely because the vaccine rendered the virus non-lethal for the community. He said, absent the vaccine, an outbreak of this size would have been an incredibly different, dangerous situation.
So the messaging focused not on the failure to stop infection, but on the success of preventing catastrophe.
Right, and that narrative reinforced compliance rather than panic.
And this brings us back to that community engagement piece, which is a socio-political factor that often sets Provincetown apart. This is a well-known queer vacation spot, a community that has historically engaged deeply with public health messaging because of the HIV/AIDS epidemic.
Right, which taught hard lessons about collective responsibility and rapid community-driven action. Did that history play a demonstrable role here?
The source material strongly suggests it did. The rapid decline was attributed in part to the community being inherently public health conscious and highly compliant.
So this ad hoc community, visitors and residents, they just got on board quickly.
Exactly. They adhered to the new indoor mask mandate, they reduced density, they used the testing resources. The sources identify that as a key success factor. This is a community that understood the stakes, possibly because of that decades-long learned history of community-led mitigation.
However, even in this compliant, highly motivated community, the logistics of tracing still faced immense challenges.
That's a vital context. The community tracing collaborative must have been stretched incredibly thin. How did the mobility of the population complicate their work?
It was an immediate logistical nightmare. You had a huge number of dispersed travelers who were only in town for a week or less before scattering across 20 states. It makes timely follow-up nearly impossible.
Yeah.
And the sheer volume of contacts, coupled with the dense, anonymous social mixing in bars and clubs, meant that standard tracing protocols were just inadequate.
And you mentioned the international workforce.
That's right. Provincetown relies heavily on an international hospitality workforce, which meant they needed multi-language support and culturally appropriate messaging, even in the middle of a crisis, which adds layers of complexity to an already overwhelmed system.
So Provincetown represents a successful experiment in containing a high-spread outbreak, but only when you have high vaccine uptake, high community trust, and a motivated, culturally informed local response. This success, though, it really highlights the systemic failures we saw elsewhere.
You've hit on the necessary counterpoint. I mean, Provincetown demonstrates what is possible when community trust and resources align perfectly. But the broader reality across the U.S. during the pandemic was a story of contact tracing just faltering where it was needed most.
Right.
We know COVID-19 disproportionately impacted vulnerable populations, non-English speaking communities, those of lower socioeconomic status, and Black and Hispanic Latino residents. And in these areas, contact tracing frequently broke down due to systemic barriers.
It's a classic case of public health infrastructure succeeding for those who already have access and trust, but failing the most vulnerable. So what were the most common challenges that inhibited cooperation in marginalized populations, things that made the P-Town model impossible to replicate?
The issues were really rooted in long-standing social and economic vulnerability. The common challenges included a profound distrust of government agencies, anticipated COVID-related stigma, especially the fear of losing your job,
Of course.
overwhelming language and cultural barriers between the tracers and the clients, and really serious privacy concerns. I mean, imagine a contact tracer calling someone in a multi-generational home where isolation is physically impossible. If that resident fears the information could be shared with immigration authorities or jeopardize their employment, cooperation is immediately compromised.
So the simple act of answering the phone becomes this huge risk calculation.
It does.
To combat those barriers, our sources highlight the Connecticut model, which implemented a community outreach specialist program. This sounds like they tried to pivot away from a purely clinical or bureaucratic approach toward genuine client-centered support.
It was a crucial pivot. The Connecticut Department of Public Health established the Community Outreach Specialist, or COS, program in 11 high-burden jurisdictions, specifically to encourage participation and provide culturally competent care.
So the mission was to shift from just asking for names to providing comprehensive support, making it easier and safer to comply.
That was the goal.
And who did they hire for these specialized roles? Because that's often where these programs fail. They hire people who don't look like or speak the language of the community they're supposed to serve.
They took a very deliberate, community-centered approach. They recruited 25 COS workers, focusing specifically on candidates who were bilingual and were already embedded in the target communities. They prioritized hiring workers fluent in languages essential to their high-burden areas: Spanish, Portuguese, Polish, and Haitian Creole. And crucially, their recruitment focused on experience in community health or customer service and basic computer literacy. There were no specific advanced educational requirements.
That's huge. It signals that cultural competency and existing community trust were valued more than traditional academic credentials.
Exactly. And that structural decision seems to have instantly improved effectiveness.
So did this client-centered strategy actually pay off quantitatively?
It paid off significantly. A cross-sectional analysis compared the COS program outcomes with the regular standard contact tracing program. And the COS program significantly improved the proportion of residents reached for contacts. It jumped from 64% in the regular program to 84% in the COS program.
A 20-point jump. That's huge when you're talking about containing a highly contagious virus.
It's massive.
And what about capturing demographic data, which is essential for understanding equity gaps?
They also drastically improved data collection for race and ethnicity among contacts, increasing capture from a low of 43% to 70%. And this improvement isn't just about better statistics, it's a direct measure of improved trust.
How so?
Well, standard contact tracers often felt uncomfortable or lacked the linguistic tools to ask sensitive demographic questions. The COS workers, being from the community, overcame that barrier.
That is such a powerful illustration of the value of cultural competence. But engagement is only half the battle. How did the COS program make sure that the people they reached could actually afford to safely isolate?
This is where the model really excelled. The key was the warm handoff. Instead of just ending the call by telling an infected person or a contact to isolate, the COS worker would directly link residents with unmet social needs to a dedicated case manager, a community resource coordinator, or CRC.
So they connect them to actual help.
A warm handoff. The COS worker would give a narrative presentation about the client's situation to coordinate vital resources like emergency food delivery, temporary housing for isolation, or income assistance to replace lost wages. This holistic, resource-supported approach is what makes compliance practically possible, not just theoretically advisable.
That structural support is absolutely vital, especially when you're dealing with the specific fears in vulnerable communities. Let's talk about Latino communities, for example.
In many Latino communities, the fear of government involvement related to undocumented status and potential deportation far outweighed the fear of the virus itself, especially with data collection.
Right.
So to effectively promote testing and tracing, community leaders had to step in and appeal to the strong sense of collective community, emphasizing that compliance was necessary to protect the entire family and neighborhood.
Shifting the focus from individual risk to collective safety.
And practically, establishing testing sites that did not require any form of identification was crucial for reducing that immediate barrier of fear and distrust.
In indigenous communities, they face their own unique barriers related to historical trauma and governance structures.
Yes, the challenges there centered on sovereignty and self-determination. For public health to be effective, it was essential to respect tribal sovereignty, meaning tribal leadership made the ultimate decisions about public health on their lands. Communications needed to use tribal languages, and they heavily stressed honoring indigenous data sovereignty principles, ensuring that the health data collected remained within the community's control and wasn't exploited by external entities. Working through established tribal leadership was paramount.
So this entire model recruiting from the community, building trust, it sounds like an investment that paid dividends beyond just stemming the immediate outbreak.
Absolutely. The sources highlight that recruiting contact tracers directly from the communities they serve should be seen as an economic development opportunity. These positions were often well-paying, with competitive wages.
Building long-term capacity.
Exactly. This approach helps build long-term public health infrastructure within the communities themselves, fostering resilience and skills rather than relying on external, transient consulting firms that vanish when the crisis is over. It shifts power dynamics and builds lasting trust.
Finally, during the pandemic, there was so much enthusiasm for tech solutions like exposure notification apps. Did technology successfully replace manual tracing in these efforts, especially in the most vulnerable jurisdictions?
In short, no. Technology faced significant persistent limitations. Digital tools proved unlikely to replace manual tracing due to a combination of low uptake, often less than 20% in some areas,
Wow.
genuine concerns over privacy, and the stark reality of the digital divide and intermittent network connectivity. Furthermore, misinformation severely complicated tech adoption. We saw rumors circulating that a chip was being implanted during testing to trace you.
That highlights the need for a trusted human to counter those narratives, something an app just can't do.
It really does.
So the lesson here is that human connection, resource support, and culturally informed outreach are the cornerstones of successful containment, even if it's slower and more resource-intensive than a simple app download.
To synthesize these findings, the Provincetown outbreak was just a critical learning moment, a high-fidelity emergency lesson in epidemiology that instantly revised our understanding of the pandemic. It showed that while vaccines brilliantly protected against severe disease, the highly contagious Delta variant, with its equivalent viral loads in symptomatic people, required immediate, radical behavioral adaptation, like universal indoor masking, even among the highly vaccinated. It validated the need for decisive local public health action.
It's such a study in profound contrast, isn't it? On one hand, Provincetown demonstrated the immense power of community cohesion, high vaccine uptake, and shared cultural experience, that unique ad hoc community, to manage a massive viral onslaught without catastrophic health outcomes. The zero-death outcome is a towering success.
It really is.
But on the other hand, the study of contact tracing challenges across the country showed that if you don't center health equity, if you don't address fear, language barriers, and resource needs, even the most basic public health tools, like tracing and isolation, will fail where they are needed most.
Exactly. The ultimate success stories, whether it was the fast containment in Provincetown or the improved client engagement through the Connecticut COS program, they hinged not just on bureaucratic policy, but on community trust, on public health strategies built around shared language, cultural competency, and concrete social support.
We learned that containment requires empathy and resources, not just clinical data and mandates.
That's it.
That brings us to the final provocative thought. The focus during the outbreak was so heavily centered on the immediate crisis, the high viral loads, the risk of acute spread, and the overwhelming success was preventing death. But given that 96% of the P-Town cases were symptomatic and the sheer number of people infected, what does later research suggest about the silent long-term risks facing that specific, highly symptomatic cohort?
That is the essential, chilling question we need to leave you with. While the Provincetown outbreak successfully contained severe acute illness, later, broader studies into long COVID highlight that even initially mild or moderate breakthrough infections can lead to severe, long-term sequelae.
Like what?
Symptoms like post-exertional malaise, severe fatigue, brain fog, chronic cough, things that affect multiple organ systems and can be disabling. These emerged as key long-term issues across large groups of symptomatic survivors. The fact that the Provincetown outbreak was contained with 0 deaths is an undeniable win, but future preparedness must also fundamentally consider the potential long-term disabling impact of mass symptomatic breakthrough infection. It's the hidden cost of surviving an infection with a high viral load, regardless of how severe it was initially.
That encourages us to consider how immediate public health data, like that from Provincetown, must immediately translate into global safety guidelines, aimed not just at keeping people alive in the hospital, but ensuring their long-term health trajectory remains intact.
We learned that containing large, aggressive outbreaks is possible in America, but that success is contingent upon 2 variables: having a highly effective biomedical countermeasure and the political will to center equity and mobilize culturally competent community resources fast.
Thank you for joining us on the Deep Dive. We hope this exploration of the Provincetown Sentinel event has given you a clearer, more nuanced picture of where the pandemic pivoted in the summer of 2021.